Okay, so thank you very much for inviting me to speak at the RAMSES meeting this year. And it's an honor to be here, especially with pioneers in the operation that we're talking about, like George and Sija. So we've been talking a lot about microvascular anastomoses, but as we all know, the circulatory system is primarily present for blood circulation to the testicles, so we'll divert our attention to the reproductive function. So when I was putting together the talk, it was supposed to be about the challenges of robot-assisted microsurgical vasectomy reversal. And as I went through the talk further and further and further, we will address the challenges, but what I really realized is what I was really ending up talking about, intentionally or unintentionally, were actually the advantages. So that's a lot of what we're going to be talking about, are the advantages, and then we'll chat about the challenges as well. So what we've been talking about all day, I think, is the dilemma with microsurgery. Should we be using microscopes or should we be using robots? And I think a lot of us are arguing in favor for robotic microsurgical techniques. So like everything in medicine, I think it's important to know where we've been to understand where we're going. So when we look at the first documented microsurgery, this was by Dr. Carl Nyland, an ENT in Sweden, who did the first middle ear microsurgery in 1910. And microsurgery then advanced in the 20th century, primarily driven by microvascular reconstruction of war-injured soldiers. And what we're talking about in this talk today is the vasectomy reversal, of course, which was initially performed microsurgically in the early 1970s. Prior to that, had very moderate or poor patency outcomes. So about 500,000 men in the United States undergo vasectomy every year. And in the US, about 50% of couples will have a divorce, which is a lot of the reasons we have so many vasectomy reversals. So about 6% of men in their lifetimes that have had a vasectomy will opt for a vasectomy reversal. So if you go, okay, 6% doesn't sound like very many, but out of that 500,000 men a year, that's about 30,000 men. So it's actually an awful lot of men. So what are the factors that impact our outcomes with vasectomy reversal? Primarily is time to vasectomy, the experience and training of the surgeon, and the appearance of the fluid from the testicular end of the vas deferens intraoperatively. So the promise of robots in surgery has been around for a long time, and we see this evidence in our pop culture. So going all the way back to 1980, when the first Star Wars movie, this is actually the second one, Empire Strikes Back, we see our robotic orthopedic surgeon here who has reconstructed Luke's hand and showing that there was interest even in the cinema culture of showing robots helping with medicine. And as we advance forward through the Star Wars series, then we see the robotic obstetrician here. We see the robotic reconstructive surgeon that Jessica also shown, so I'll sit by that. Of course, what we're talking about today, and what we have presently to use, is the Da Vinci system. So this was up in the treehouse of one of my former mentors, Dr. Bill Steers, who was a big loss that we lost him to cancer this past year. And this is where he actually used to edit the Journal of Urology as the editor-in-chief. And he had up on the wall there, Isaac Asimov predicted in 1976 that I would someday be operating with a robot, and by golly, he was right. So robotic surgery's evolution. We started with the Puma. This was designed for brain biopsy. The Probot was a urologic device that was used for transurethral resection of the prostate, and you'd have image feed into that had volume and dimensions anatomically. There was the RoboDoc that our orthopedic colleagues used. There was the PACU. This is for the percutaneous access to the kidney, for the collecting system of the kidney. This was designed at Johns Hopkins. There was the Artemis that was designed in London. It was discontinued due to a lack of funding. However, this was the first master-slave robotic system. This is the ESOP. This is really primarily for control and direction of the camera with laparoscopy. And I remember when I was about 15 years old watching my father do gynecologic surgery with this, thinking it was just the most amazing thing in the world. And it's amazing to see how far we've come with leaps and bounds in a relatively short period of time for robotic technology. This was the Zeus. It combined the ESOP with the Artemis, basically, to be a console master-slave system. And then, of course, we've advanced the Da Vinci. which in 1997 was initially used for robotic cholecystectomy. I think we all know the components, we're familiar with it, the 7 degrees of freedom. It was originally designed for telesurgery for battlefield and remote environments. There's been a lot of talk today about how we need to probably get back to that use as far as remote surgery. But it's been found to be more useful for minimally invasive surgery, and now it's being advanced for microsurgery, basically replacing the operative microscope with a robot. So publications, what's been published on robotic vasectomy reversal. In 2004, there was an ex vivo robot-assisted vasovasostomy that showed elimination of tremor and comparable patency rates. Also in 2004, there was a study looking at robot-assisted vasovasostomy as well as robot-assisted vasoepididymostomy in a rat model, and again showed improved stability and motion reduction during suturing. In 2005, there was a multi-layered robot-assisted vasovasostomy in a rabbit model, and in 2010, Dr. Pericotto published the first human study of this, showing shorter operative times and a higher mean sperm count postoperatively. We validated that in 2014, showing equivalent operative times, equivalent patency rates that did not have a statistically significant higher rate when comparing them to our microsurgical series, but it was higher raw number of patency patients, and we had equivalent concentration and total modal sperm counts postoperatively. And in our robotic group, there was a faster mean time to pregnancy by 4 months than in the microsurgical group. So this is what a vasovasostomy anastomosis should look like. You want to have the perivasal adventitia for blood supply. So it's really all about efficiency, which is a lot of what we talked about today. So sure, we can change the tire using our old tools, or we can do it like the F1 Ferrari team and use a little bit higher level of tools and try to be more efficient. I just like that analogy because I think it's a cool video. But what it comes down to, I think, is in the words of Steve Jobs, good is not good enough. So yes, we've done microsurgical vasectomy reversals for quite some time with excellent outcomes, but if we can push technology and push the abilities and increase precision and make some advantages for the surgeons, why wouldn't we? So what are these advantages that we're talking about? And this has been talked about quite a bit today, but we do get elimination of the tremor, improved stability, 7 degrees of freedom of the instrumentation, surgeon ergonomics, decreased surgeon fatigue. Again, like CJ mentioned this morning, if you have case after case after case, you can go through these with robot assistance with very minimal fatigue and feel like you could do another one when you're done, which is not necessarily the case with a pure microsurgical technique. A scalability of motion that we've discussed quite a bit, the 3D HD visualization, the ability to manipulate 3 surgical instruments and a camera simultaneously, giving you complete control of that operation with very minimal need for a skilled specialty microscopic assistant. So there's a de-emphasis on the need to have that same assistant every time that is able to do those microsurgical skills with you, that you don't have to worry about their part of the operation. The unchanged surgical field, if you're doing a high complexity microsurgical reconstruction, a vasoepididymostomy, and you need to take a break and you step out of your console, put your head right back in, and nothing in your field has changed. Everything's exactly how you left it. If you do that in a microsurgical case, you're going to have to readjust everything. Everything is moved. Your visual field has changed. Your depth of focus has changed. All these things. Operative time, there is a learning curve with this, but we see improvement in operative time with volume. So this is a 9-0 suture that we use for a typical vasovasostomy. And this is just showing, so we talk about 7 degrees of freedom and what that means when we're talking about working in very small confined spaces with tiny lumens. This is showing you about the extent of what a microsurgical movement that can be made with the human hands and wrists are. When we're talking about the robotic movement, of course, I think most of us are familiar with the 7 degrees of freedom that we can get, but it allows for a much more fluid operation that's a little bit more seamless. So on that same level, microsurgical suturing, this is a simulation that was set up with plastic tubing. And you can see it's certainly doable. We all have and do this, but there are some limitations on the movements. Again, the idea of the tactile feedback being a limitation with robotics, with this type of suture and tying, if you tie down this knot with your eyes closed, you will not be able to feel when that knot is seated. So really, it's your visual cues telling your brain when that knot is down with that level of microsurgery, just like it is with robotic microsurgery. So it's not all that different from a tactile feedback standpoint. So this is again just showing the difference, and you can see really how elegant it is using the robot for microsurgery. It's just a really nice, elegant, smooth, seamless movements. So it really minimizes a lot of the extra movements that we may not need. So this is what the microsurgical repair looks like at a high magnification. This is a vasostomy. Remember, we're talking about vasostomies depending on the area of the vas deferens we're talking about. We're talking about in the straight vas deferens about a 0.7 millimeter lumen that we're approximating and anastomosing. When you get to the convoluted vas deferens, we're talking about a 0.4 millimeter lumen. And then when we're talking about vasoepididymostomies, it's about a tenth of that. So it's an extremely high level of microsurgery to get good outcomes with this. And you can see, no microsurgeon likes to admit that we have any level of tremor. The fact is, it may be different limits for each surgeon, but everybody at high enough levels of microsurgery has some level of physiologic tremor, as much as we may not like to admit it. So this is the robotic technique with a very similar case showing a vasostomy. This is all done through about a 1 centimeter incision in the scrotum, so it's a slightly smaller, a larger incision than one of the vasectomy incisions as an outpatient procedure. The guys have a very similar recovery to their vasectomy, actually. So you can see again how elegant this is, how smooth it is, and it's just a more fluid movement. So putting them on the same screen, if you can just toggle your eyes between the two, when you put them on the same page, you can really see the difference between the tremor, the level of magnification that we have here is relatively equivalent. You can see that the visualization is very nice on both sides, but you can get a very good visualization at this level of magnification robotically. And again, you can just kind of see some of the fluidity of the robotic technique versus some of the less fluid nature of the microsurgical one. So it is. It just gives you some of that stability that we all like. So I love this curve. This is the Gardner-Palmer Tech Hype Curve. And you can apply this really to anything with technology, whether we're talking about robotic surgery, Teslas, iPhones, whatever. So whenever there's a new technology, the visibility goes up immediately. And there's that technology trigger, and you get a peak of visibility. And then there's the peak of inflated expectations. This technology can do everything. Everyone is very excited. This is it. This is the best thing that we've ever had. And then there's the trough of disillusionment, which is where everybody goes, well, it can't do this, this, and this actually. And these are the problems with it. And no, we don't like it anymore. And then it evens out the slope of enlightenment until we hit the plateau of productivity, which is where what can technology actually do and what's it useful for. And I think this is very nicely applied to robotic microsurgery. High expectations. There's a lot of naysayers that say, well, here are the disadvantages of it. And then it evens out somewhere between where we go, this is where it's useful, and these are the advantages we can gain from it. So learning curve, is this a challenge? I'll just tell you from my personal experience, I'm a microsurgical fellowship trained reproductive urologist. So when I went through my 6 years of urology residency, it was right when we were transitioning from open surgery to robotic surgery, which means for the most part, I stood by the table and assisted while my attendings were learning how to use the robot. I had very little console time, and then I did a 2-year fellowship that was dedicated to microsurgery. So I was formally trained as a microsurgeon. I spent time with Sidjo down in Florida, and he showed me the technique, and I took it back to my home hospital and started doing these cases. So I had very minimal robotic training, and I was able to translate this microsurgical technique into a robotic microsurgical technique without any drop off in my outcomes. So I was able to publish these results last year, which showed, again, equivalent operative times, equivalent patency rates, with a higher raw number of patent patients with the robotic arm versus the microsurgical arm, equivalent sperm concentrations, total motile count, and again, a faster mean time to pregnancy by 4 months in the robotic group. So right now my series is around 75 patients, and when you break it down by interval of obstruction from the time of vasectomy, my patency rates at the first 8 years are 97%. The 8 to 15 years dropped to 95%, and after 15 years have been about 75% with the robotic technique. So those are clearly equivalent, arguably potentially better than some of the microsurgical data out there. So other challenges to setting up your robotic microsurgical program. So cost is always an issue that comes up. A lot of this depends on where we practice and what the setup is. If there's a robot in the hospital, a lot of times it's going to be utilized, at least in the States. And so the major cost has already been paid for. Yeah, you've got disposable arms that have 10 cases lives on them, but comparatively to open cases, that's not a huge difference. Some of this takes work from the surgeon if you want to build your program bad enough. I really went to my hospital, went to my CFO, and from cost from a patient standpoint, really had to do a fair amount of work to get the cost where we need it. But I'll tell you right now, in my program, it's only a $300 difference between microsurgical and robotic microsurgical. So most of the patients do opt for the robotic. Establishing a program, it takes effort. OR time, getting that robotic time, if you're in a center that has very busy robots or doesn't have enough robots for the volume they're doing, you have to prove that you're going to be efficient on that to gain more time, but that's very doable. Outcomes, technically getting used to using this platform. There's a dogma out there with microsurgery. I think this was addressed a bit earlier, but there is a lot of backlash towards this technology. So we have to show outstanding outcomes that are at least equivalent, if not better, to traditional microsurgical outcomes for this technology to flourish, and I think we are doing that. Innovation is never easy. We have to push technology. I love everything that we've heard today. I think that we are trying to push the technology and make it better and better. Techniques are continuously evolving. Results are surgeon dependent at this point. Again, we're translating microsurgical technique into robotic microsurgical technique, especially at the higher level operations microsurgically. So we're taking the same principles of tissue handling and translating that to a robotic technique. So it is surgeon dependent at this point. Ultimately, I think the goal is widespread adoption by multiple surgeons. I think at this point we still have to be very careful about that, because if there are surgeons that aren't trained at the appropriate level for this type of surgery and they don't get the outcomes that are expected, what's going to be damned is the technology, not the surgeon. So we have to be very careful about not having that happen and then people saying, well, see, the robotic technique's not as good. You have to compare apples to apples. So what's next is improving robotic microsurgical instrumentation for the Da Vinci or other robotic programs that we've heard about. So I think both we're seeing happen to optimize a robotic platform for microsurgery and improving magnification and decreasing pixelation. There is a limitation to the amount of magnification that we have right now. So the evolution has been where we started out using just our eyes visually for microsurgery. We advanced to loops. And then the big jump was leaping towards microscopes to really improve outcomes. And now we're evolving to push our technology to robotic microsurgery. Any questions?